So our work started back in the days that we started understanding that there was a bidirectional link between diabetes and periodontal disease. And that's how everything really started. And then eventually there was a long list of diseases that were connected with the oral diseases, including periodontal disease. Periodontal disease is both an infectious disease and inflammatory disease. Separate from this one, I started working with Dr. Serhan back in 1999. And when our first research started was the first generation of Naproxen A4 and Resolvin E1. And eventually we wanted to combine these models. And of course, brain is one of the most difficult areas to reach with any of these compounds. And in the meantime, there was emerging evidence that there was a link between Alzheimer's disease, neurodegenerative disease at large, with the periodontal disease. And we started asking if there was an inflammatory combination in this one, if there's an inflammatory connection between these. Can we basically attack this common inflammation through these SPMs? And that's how everything started. And we published several papers, not only on the epidemiology aspect, but also now we're getting into the biology and molecular understanding of how this mechanism really works. And now we're seeing that if you can target one disease, you can also affect the other disease. There's an advantage of this from a dentist perspective, because as opposed to all the other organs, you can open up everybody's mouth. So you can actually basically use any of these compounds very easily in animals and humans, as opposed to going directly to the lung, to brain, or to liver, or any other internal organs. So we use the compounds or the strategies not only to treat periodontal disease and affect systemic diseases, including Alzheimer's disease, but it's also very important to use this as a delivery system coming from the oral cavity, not as a pill directly, but also as a absorbent from the mucosal surfaces, getting into the system and getting much faster delivered to the system. So that's, I think, our two contributions there. Obviously, there's a third contribution. We also showed that if you treat periodontal disease, you can also reverse the signs of Alzheimer's disease, at least in mice, and hopefully we're going to be able to translate these findings in humans as well. So there's again a two-way relationship between the neuroinflammation, neurodegenerative disease and periodontal disease and oral disease to that extent. So in one large study that we published with a huge cohort from Taiwanese population, about 1 million people for 16 years being followed up, we showed that there's a risk of increased oral disease, increased periodontal disease in dementia, and a subgroup of Alzheimer's disease, in addition to that, about almost twofold. So with the same group, we also showed that there was also reverse was true. So you can, when you have a large cohort like this, and you cannot debate against these type of large clinical trials or large epidemiological trials, that you increase the risk of dementia, you increase the risk of neurodegenerative disease, including Alzheimer's disease, by almost like twofold if you have periodontal disease, untreated periodontal disease. So in a way, you can treat one disease and affect the other disease. So this doesn't mean that gum disease, periodontal disease, oral diseases can cause Alzheimer's disease. That's not the message that we want to give. This doesn't mean that if you don't brush your teeth, you're going to get like dementia first. But what it really means is that if you take care of the common risk factors out of this equation, including obviously inflammation, which is the major risk factor, this is the denominator of all these diseases, then you can help the other disease control. What the practical terms this means is that if I'm managing my patients appropriately, if a dentist, if a periodontist is in the medical team's membership, so that they can be also referred patients back and forth, we can help our medical colleagues much better. So if you can take care of the inflammation, many diseases, including Alzheimer's, including Parkinson's disease, then the drugs that are going to be effective in the clinical terms are going to be needed in much lesser doses, or the management of these patients will be better. So the key here is to make sure that you can control the periodontal disease, which we can very easily treat this, obviously, and not only to take care of the disease, but also manage the aftermath of the disease that can allow our medical colleagues to manage the diseases on their side as well. So I think that's the major paradigm shift in understanding the link between the oral disease and systemic disease. And I think our group is doing a huge impact on doing that change of the paradigm. There are some causative reasons. This doesn't mean that the oral diseases are not going to cause other diseases, but we're not trying to stretch that too much because, yes, obviously there are certain bacteria living in the mouth that can make diseases. For instance, there's one bacteria called Fusobacterium nucleatum that is being discovered alive in pancreatic cancer, colon carcinoma, in adverse pregnancy outcomes, in certain other diseases. And there's only one source of this bacterium that's coming from the periodontal disease, from the oral cavity. And that is existent in everyone. So that doesn't mean that it's a bug that's going to be harmful by itself. But what triggers this bacterium's harmful effects is really either the inflammation that is actually locally increased in the oral cavity, which is becoming a much more of a systemic impact, or it is the distant organs inflammation, which can be attracting other cell types that will translate or transmit these bacteria. So that doesn't mean that we're excluding the potential of oral diseases causing other diseases. However, this is one segment of the entire spectrum. So for most of the times, we are basically, entire body is changing the set point of general inflammation. This is also true, the link between Alzheimer's disease and diabetes, for instance. If you have obesity, if you have diabetes, you increase the risk of getting Alzheimer's disease. So with the same token, you basically create that risk by the oral disease as well. And in animals, for instance, when you want to generate Alzheimer's disease, especially in rats and rabbits, you basically put them on high-fat diet. So that can create a Alzheimer's disease-like symptoms. Animals don't get into Alzheimer's disease, just like in humans, and we don't know the reason for that too much. However, you can induce the Alzheimer's disease-like pathologies in the animal models, very similar things that as we see in humans, that they cannot find their way, their cognitive skills are gone, and then they also have extensive increase of their amyloid beta plaque formation in the brain. So that's a very interesting and important point. And so our argument is that if diabetes can make this, if obesity can make this, periodontal disease can also make this. And that's exactly what the line of thought that we're having this. And there's also a lot of literature showing that there can be a link between the gut microbiome versus the Alzheimer's disease risk. And now we're having evidence that the oral microbiome, the microorganisms living in the oral cavity, can also cause the increase of the Alzheimer's disease like pathologies in the brain as well. So that's actually very interesting and very recent findings from my lab actually. You can either take these magic pills of SPMs, obviously, which is something that's not readily available right now. However, we also did the first clinical trial in humans that was FDA approved clinical trial at Forsyth Institute in humans. It was a safety clinical trial. It was a phase 1, phase 2A clinical trial with the using of the benzodiazepoxide A4. So that was the first ever human FDA clinical trial. And it was not only perfectly safe, but the endpoint was human periodontal disease. And that was also by just using a mouth rinse, we were able to reduce the signs of inflammation. We were able to increase or decrease the pocket depth, and which increased the efficiency of the oral care. So that was very encouraging. Now we're actually trying to do the second B phase and eventually do a larger clinical trial as a proof of concept. So that is coming from, of course, the synthetic compounds. So until all of these compounds are going to be readily available, the way that you can get to this point will be using either omega-3, omega-6 fatty acids, heavily omega-3 fatty acids, fish oil, or other compounds that were discussed this morning as well. So nutrition plays a role. And I'm working on a separate cohort of a group of subjects. I wouldn't call them patients because they were all super healthy. And some of them are doing change of their lifestyle and change of their diets. Now we're studying their saliva and blood content of the compounds that are important. So when you're using the nutrition as a tool, when you're using lifestyle changes, exercise as a tool, it takes much longer. So now we are trying to see how long would it take. I have 43-year long data on this group. And this data shows that the tipping point will be about like 8 to 10 years before you actually can see this. So nutritional products are perfect, but we're also changing our own behavior, our own, in a way, epigenetics based on the nutritional income. And obviously, if you're from the Mediterranean, just like me, you're much more blessed than somebody with a Western diet, but it takes much longer. So yes, we can reach to that same destination, same goal by changing our nutritional intake of a lot of the drugs, a lot of the compounds, or a lot of the natural products. But there's always going to be room for expediting this, especially with patients who are suffering from a lot of these chronic diseases. And moving forward as a clinician, I would use a lot of these nutrition products as preventive strategies, but we have to develop much faster delivery systems as therapeutic. And that's the reason why there has to be a good relationship between the industry and academia and clinicians, of course, as the end point of users, these, to make sure that these products are going to be delivered at the right time to the patient's hands who need them now. They cannot wait for 8-10 years to be able to recover or reverse the signs of inflammation. And that's very critical to emphasize in terms of this. What we are doing is translational. Basically, my lab works on cell models to all the way to preclinical models to human models. And at the end of the day, I'm a dentist, I'm a periodontist. I work with my patients every week, many times. So for me, of course, I'm learning a lot from the molecular biology, but I think our major impact, major contribution is really to use this as a change as a periodontal disease. So I know my limits, obviously. But so what our research has shown, in addition to what we already discussed, another mechanism how the host cells, how the body's own cells can migrate, transport the bacteria from one location to another one in the body. So in a way, for most of the diseases that are infectious in nature, you may see some bacterial presence in the circulation. But for most of the diseases that are actually chronic, you don't see a lot of these bacterial presence. You don't see sepsis, you don't see bacteremia readily. For someone with extensively bleeding gums, going to my chair, we did those experiments and there was no bacterial presence in the circulation after cleaning their mouth. So that prompted the question about how these bugs can go from one place to another one. As we discussed before, and also in preclinical models, we discovered that brain can be a place where the oral bugs can travel live, which is not a good sign, obviously, which is not something that we want to hear, but they are there. And this is repeated and reproduced for multiple groups in addition to ours as well. So how do these bacteria can travel from one location to another one? We came up with a hypothesis. This was already coined in the medical terms, which was called Trojan horse hypothesis. Just like Trojan horse idea, how Troy fell into Greek invasion after the Trojan War, the bacteria can hide in our own tissues that are supposed to protect us from those bacterial effects and supposed to kill them. Some of these bacteria, including the species that I mentioned before, Fusobacterium nucleatum, resist the killing of the body's cells. So they can travel and they use these as much more cargo ships from one location to another one. People have shown this in the medical field for other bacteria, viruses, and really nasty ones. So we were the first ones to show it in a context of a human oral pathogen, Fusobacterium nucleatum, to go from one organ to another one. This is something that we're extensively working on. And this is actually one of the most recent contributions to the field, especially in the context of mixed infection and inflammatory diseases such as periodontal disease. Certainly, Alzheimer's disease is going to be one of the targets because these bacteria are so small and that they can pass through the blood-brain barrier, or they can actually travel through the circulation, getting into the brain without being completely devoured by the human defense systems. And that's, I think, one of the hypotheses that we're actually going to be testing for the next few years, going to keep us busy. And that's an important question because I've been a scientist for 33 years. I've been a dentist for 33 years, and I don't have that much, like another 33 years at least, I'm not going to be around. But the research will continue. So before, for the next generation of researchers that I'm training in my lab and in my teams, what we're trying to pave the way is to make sure that they understand the basis of these, and they're dealing with much more complex diseases. So, and one of the things that I love to see when I retire is to find ways to change another disease by modifying another disease pathway from here. And that's what my future research is going to focus on. And to do this is much harder than just looking at one animal model, one disease, one isolated cell type. Or I'm not saying that these are not important, but what I'm saying is that these are not going to answer much more complexity of the human diseases, because it's very rare that in medicine and in dentistry that one organ is completely isolated from the effects of the other. And that's something that we're bringing back to the understanding of medical education and dental education to that sense. So that's one of the things that I would like to do. Specifically when you're moving forward in terms of treatment strategies, the days that we're going to be looking into only one drug treating one disease are gone. The diseases are much more complex right now, and they're all interconnected. So I think one of the areas that we've been publishing, and we'll continue with this, will be looking at the polypharmaceutical approaches, lifestyle changes. Basically, why shouldn't we use any natural products in the meantime? Because that market is much bigger than many of the drug markets in the US. So many people are going to CVS and going other places and using a lot of these basically natural products for their diets. So we should take the advantage of that, and I think there's going to be a lot of need for a lot of bioinformatics to be able to tease out which one is coming from the natural changes of people doing exercise and so on and so forth. Another thing that we should be also looking into is to use these as biomarkers, and to that end I think dentists and periodontists can also bring a lot of knowledge to the table, because we are the ones working with saliva. We know how the saliva works, and saliva is of course much easier to work with than blood or urine or cerebrospinal fluid. And my lab has also been working with saliva diagnostic for the last almost 20 years right now. And whatever we can detect in circulating blood, plasma, serum, we can detect in saliva too. And this is also true for all of the small locations. So, and there was a lot of discussion for the last 3 days about, can we use these SPMs as salivary diagnostics as well? Can we use other markers for salivary diagnostics? So I think that's also going to be a very important game changer for defining the success, because we think that we're very successful as a clinician, but how do we define success in the long term? How do we maintain that success? How do we make sure that the patients are not going to get into the same problems if we don't know how to measure the reversal of this? And that's going to be another contribution I'm hoping to make in my career.